Sir, you can unmute yourself, then start.
Yeah. Hello, good evening, everyone. I am audible, Shailesh.
Yes, sir. Yes, sir. You can start.
Yeah. See, I thought we will divide our topic into everything to cover at one go is difficult. I thought I will divide into one is a genetic epilepsies and second one is a focal epilepsies. And today I will speak about the genetic generalized epilepsies. I have a few videos of the generalized epilepsies. I will show those. And see, the idiopathic generalized epilepsies constitutes nearly 1/3 of all epilepsies. They are genetically determined and affect otherwise healthy people of both sexes and all races. And idiopathic generalized epilepsies manifests with typical absences, myoclonic jerks, and generalized tonic-clonic seizures, either alone or in varying combination and the severity. Whatever IgE you take, it is a combination of the things. The one is a absences and the second one is a myoclonic jerks. The myoclonic jerks can be restricted. Either they can involve only eyelids, or they can involve only neck, or they can involve only upper body, or they can involve the only lower body. So the jerk can be anywhere. And the other one is a generalized tonic-clonic ones. So you see the combination of these things with varying severity. So the diagnosis is usually easy, although IgEs are frequently misdiagnosed as non-epileptic or as other focal and the symptomatic epileptic disorders. EEG is the most sensitive test in the diagnosis and confirmation of the our idiopathic generalized epilepsies. EEG is unlikely to be normal in untreated patients. If you have 3 EEGs consecutively done over a period of time are normal, it is unlikely to be a IgE. The diagnosis is usually easy, although the treatment of IgEs is fundamentally dependent on syndromic characterization. It is highly rewarding for the doctor since when treated with the appropriate anti-epileptic drug, the majority of the patients will become seizure-free. So in ILA in 1989 classification, they divided the generalized epilepsies into idiopathic, symptomatic, and the cryptogenic. Idiopathic means there is no underlying cause other than the possible hereditary predisposition. Symptomatic means epilepsy is a consequence of a known or suspected disorder of the CNS. Cryptogenic refer to disorder whose cause is hidden or occult. So idiopathic generalized epilepsies, by the definition as per 1989 criteria, all seizures are initially generalized, and EEG shows the generalized, bilateral, synchronous, and symmetric discharge. If you see generalized, bilateral, synchronous, and the symmetric, this generalized can be restricted generalized. Means you can have a bifrontal synchronous symmetric, or biparietal synchronous symmetric, or bioccipital synchronous and symmetric. If you have a synchronous and symmetric discharges in the homologous leads, then you can call it as a generalized. So you can use the term like a frontal dominant generalized, parietal dominant generalized, or occipital dominant generalized, based on the which homologous leads are showing it. Patients are usually has a normal interictal state without neurological and the neuroradiological signs. Interictal EEG shows the normal background activity, and generalized discharges such as spikes, polyspikes, spike and wave, or polyspike and wave discharges, 3 or more than 3 Hz spike and in frequency. So initially the idiopathic generalized epilepsies are characterized based on from the age of onset. One is a benign neonatal familial convulsions, benign neonatal convulsions, benign myoclonic epilepsy in infancy, childhood absence epilepsy, like a juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with grand mal seizures on awakening or GCS on awakening, and other generalized epilepsies not defined above, epilepsies with a seizure precipitated by specific modes of activation. So what we commonly encounter in the epilepsies, most common ones are childhood absence epilepsy, juvenile myoclonic epilepsy, and GTCS on awakening. So if you see from the age of onset, like in the myoclonic epilepsy in infants, myoclonic epilepsy with myoclonic atonic seizures, like a Deuce syndrome. Next, childhood absence epilepsy, epilepsy with myoclonic absences, stationary syndrome, and the febrile seizures, and JAE, juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with the GTCS. And this is the recent revised terminology. And in this one, major change in 2001 goes from the classification to the organization of the epileptic syndromes. These epileptic syndromes organized, it is more like a electroclinical syndrome based on the EEG and the clinical. And the second one is a etiological syndrome. Also recommended changing the nomenclature from the idiopathic generalized epilepsy to genetic generalized epilepsy. And this is the same from the base. These are the electroclinical syndromes are divided based on the clinical feature and the associated EEG features in the neonatal period, infancy, childhood, adolescence, and the familial epilepsy syndromes. Like these the same ones which are characterized based on the age of onset and EEG. So etiologically, they divided into genetic, structural or metabolic, and unknown, which is equivalent to our previous 1989 classification. Genetic is equivalent to idiopathic, structural or metabolic equivalent to symptomatic, unknown to the cryptogenic. The later expanded to the 6 groups like a genetic, structural, metabolic, and immune and infections came into the other 2 divisions, and other one is unknown. So genetic generalized epilepsy, current ILAE recommendation favors the nomenclature of the genetic generalized over a idiopathic generalized epilepsy. Genetic basis for the most IgE syndromes have been established either in the form of the specific gene mutation or association with the strong family history. So I will go through the one by one, just a few minutes. I will just on the videos and I will get back to you. Okay, genetic generalized epilepsy syndromes. We will just go through the few syndromes and then I will show the videos. So epilepsy with myoclonic astatic seizures. This is also called the DOOS syndrome. They are polygenetically determined, was previously classified as a cryptogenic or the symptomatic generalized epilepsy in a ILAE 1989 classification. But like you know that now, like almost most of the case reports are coming from the lot of genes which are causing the DOOS syndrome. And what is like normally the presentation will be like this. You will see a child who is of the 5 to 7 years old coming with the drop attacks. Sometimes we will mistake these drop attacks because of the age group. One is we will consider SSPE kind of thing. And they also have a myoclonic jerks. And that SSPE also, the post-measles SSPE also can have a drop attacks. They can have a myoclonic jerks. But here, based on the history, like more than 2/3 of the patients have a febrile and afebrile GTCS. And then subsequently, they start having the myoclonic seizures and the drop attack. Astatic means drop attacks. Normally, these DOOS people drop onto the buttocks. So if you are encountering a child with both febrile and afebrile generalized seizures, and now maybe at the age of 5 or 7 years started having a drop attacks and myoclonic jerks, consider the DOOS syndrome or myoclonic absences. So inclusion criteria is a normal development prior to the onset of the seizures and normal MRI. Onset of the myoclonic, atonic, and they can come independently or they can come together. So they can be independent. One time you can get the myoclonic, one time you can get the drop attack, or they can come together. Between the 7 months and 6 years of age, normal background activity, and with if you see the EEG, you can see a 2 to 3 head generalized spike and wave discharges without the focal spike discharges. And exclusion criteria, like one is a Dravet syndrome that also can have a febrile and afebrile seizures and polymorphic seizures, like where you can see a drop attacks, you can see a GTCS, you can see a myoclonic jerks, same as LGS, and myoclonic epilepsy in infancy and other epileptic syndromes where you can have a myoclonic and atonic seizures and the tonic seizures. So SCN1B and the gamma aminobutyric acid receptor subunit gamma 2 mutations are commonly associated. So we are talking about the DOOS syndrome. So what are the core points in the DOOS syndrome? It is a myoclonic astatic epilepsy. So child will have a febrile and afebrile GTCS and suddenly starts having the myoclonic jerks and the drop attacks with normal intellect and normal MRI. And the interictal EEG normal during the initial febrile and afebrile GTCS. When myoclonic or atonic seizures appear, there are a frequent clusters of the 2 or 3 head generalized spike and wave discharges interrupted by the high amplitude slow waves in a cases with a prominent atonic or myoclonic atonic seizures. Normally, myoclonus will have a like a poly spike and wave discharge kind of thing, whereas atonic one comes during the slow wave during the slow waves. So if somebody has a poly spike followed by the slow wave, you will have a myoclonic jerks during that poly spike and you have a drop attack during that slow wave. So half of the patients achieve the seizure-free state and normal or near normal development. These may correspond to the idiopathic form of the DOOS syndrome. The others probably belong to the symptomatic or cryptogenic cases, or other syndromes continue with the seizures, severe impairment of the cognitive functions and behavioral abnormalities. Valproate is the most effective AED. Add-on or small doses of the lamotrigine have a beneficial pharmacodynamic interaction with valproate. Whereas topiramate reduces the frequency of the atonic seizures, levetiracetam may also be an effective. So, but when we are combining the valproate and topiramate, just to be careful with the increase in ammonia level. And try to avoid the sodium channel blockers like a carbamazepine, phenytoin, and the vigabatrin are contraindicated. Myoclonic and atonic status epilepticus, intravenous benzodiazepines are often efficacious, but may rarely precipitate the tonic status epilepticus. In resistant cases, ketogenic diet alone or followed by the ACTH and ethosuximide have been found to be highly beneficial. So this one, all of us will know about childhood absence epilepsy. It is an abrupt, brief, severe impairment of the consciousness with unresponsiveness and interruption of the ongoing voluntary activity, which is not restored during the ictus. And it is an abrupt, brief, severe impairment of the consciousness, which is of a few seconds. The duration varies from the 4 to 20 seconds, although most often it is around 10 to 12 seconds or 10 to 15. Absences are severe and frequent. You can see the hundreds per day, and they have an abrupt onset and abrupt termination. And automatisms occur in 2/3 of the seizures, but are not stereotyped. Ends with the like if they are doing some activity, once the seizure comes, they stops the ongoing activity. Once the seizure ends, they resume the same activity, and they don't even remember that, and nearly invariably provoked by the hyperventilation. So sometimes it will be when we are encountering the first time the brief loss of consciousness or awareness and associated with the automatisms, we might consider even a complex partial seizures, which might coming from the temporal lobe or frontal lobe, can also have a, without aura, they can have a behavioral arrest and some automatisms, and immediately they will resume their activity. So the difference, if you see between the typical absences and complex partial seizures, one is the duration of the seizure. If you see, the duration is always less than 30 seconds in a typical absence. But whereas complex partial seizure normally lasts between 2 to 3 minutes. And the duration more than 1 is almost exceptional for a typical absence. And it is a rule for the complex partial seizure. Non-convulsive status epilepticus is common in a typical absence and rare in a complex partial. And almost you can see typical absence, you see daily hundreds of the seizures. Whereas complex partial seizures, you see some 3-4 per month in a regular. And typical absence is associated with the simple automatisms. Complex automatisms, complex hallucinations, and was rare. As we noted earlier what I told, in a IGEs are commonly associated with the myoclonic jerks. These myoclonic jerks can be in the eyelids or the neck or the facial muscles or upper limbs or the trunk. It is very unusual for the complex partial seizures to have a myoclonic jerks. Sometimes you can see a eye blinks in a complex partial seizures, but that is in association with the other ones. Evolving to the other focal seizure manifestations never happen in the typical, but it can happen with the complex partial seizures. And typical absences always have a sudden onset and the sudden abrupt termination. And that is not a very frequent in a complex partial seizure. There is no postictal symptoms for the typical absences. You can see a postictal features in a complex partial seizures. Hyperventilation can reproduce the absences more commonly, complex partial seizures rarely. Photic can elicit the typical absences and not the complex partial seizures. And most important thing is all our syndromes are electroclinical. So EEG always shows the 3 to 4 Hz spike and wave discharges in a typical absences, and very rare and almost nil with the complex partial seizures, except sometimes in a frontal absences. If sometimes it can mimic the typical absence, but in terms of the EEG. Interictal generalized discharges are frequent in typical absence, and it is exceptional in a complex partial seizures. Interictal focal abnormalities of the slow waves are rare in typical absence, frequent in complex focal seizures. Normal EEG in untreated state is exceptional. As we told earlier, in an untreated IGEs, EEG is always abnormal. So, like being a most common one, few things to remember is a abrupt onset and abrupt termination of the event. The duration of the event is almost not more than 10-15 seconds, and it comes hundreds per day, and a very clear association with the EEG 3 to 4 Hz spike and wave discharges. So loci at various chromosomes have been identified, but not very specific. Interictal EEG, normal background with a frequent rhythmic posterior delta activity, focal spikes are common. Ictal discharges consists of the 3 Hz generalized spike and wave discharges. Generalized spike and wave discharges are rhythmic around the 3 Hz with a gradual and regular slowdown towards the termination. So prognosis excellent. Remission occurs before the age of 12 years. Less than 10% of the patients may develop the infrequent or solitary GTCS in adolescence or adult life. Male gender and an earlier age of diagnosis may be associated with the need for 2 medications for seizure control in childhood absence epilepsy. Duration of the illness, seizure frequency, AED treatment were related to the severity of the cognitive, linguistic, and the psychiatric comorbidities. The brain MRI showed significantly smaller gray matter volumes of the left orbitofrontal gyrus as well as left and right temporal lobes compared to the children without epilepsy. Monotherapy with either valproate or ethosuximide control absences in 80% of patients. Small doses of the lamotrigine to valproate may be the best combination in resistant cases. Drug therapy can be gradually withdrawn after 2 to 3 years of free of seizures. Contraindicated drugs, either because they are ineffective or make the seizures worse, are carbamazepine, gabapentin, oxcarbazepine, phenytoin, phenobarbital, pregabalin, tiagabine, and vigabatrin. So try to, in any IgE, if we know very clearly that we are dealing with some IgE syndrome, try to avoid the sodium channel blockers, because in some people they might precipitate the worsening of the seizures and they may not be as effective as a broad spectrum ones. And the third epilepsy, first we saw the Deuce syndrome. I will show the EEGs at the end. Second one is a childhood absence epilepsy. Third one is a epilepsy with myoclonic absences. About 1/3 of the cases with epilepsy with myoclonic absences are idiopathic, and are included under the idiopathic generalized epilepsy. The others are the symptomatic cases. Clinical manifestations onset from the first month to the early teens, peak at 7 years, boys affected more than girls. And these manifest with the impairment of the consciousness, which varies from the mild to severe, and the rhythmic myoclonic jerks, mainly shoulders, arms, and legs, with concomitant tonic contraction. So here also, if you see the name of the disease is the myoclonic absences, means you have a myoclonic jerks associated with the absences. So myoclonic jerks, if you see here, where are the predominant jerks? Are on the shoulders, arms, and the legs. So the duration of the absence varies from the 8 to 60 seconds. The myoclonic absences may occur many times per day. Other seizures such as GTCS or atonic fits occurs in 2/3 of the patients. If you see the duration of the absence here can last up to 60 seconds, whereas in a childhood typical absence seizures, you have a maximum duration lasting not more than 15 seconds, an average of the 10 seconds. So if the based on the duration of the absence, you also know that what kind of disease you are dealing. So just I will show the video of this myoclonic absence. Shailesh,
Yes, sir.
are you able to see the screen EEG?
No, sir, not. Now something is happening. Yes, now it is there.
Are you able to see?
Yes.
Okay, I will show you the one video. Shailesh,
Yes, sir.
hello.
Yeah, sir. Go ahead.
Shailesh,
Yes, sir. Go ahead.
yeah, just
You are audible.
okay. I need somebody to comment. You take that role.
Yeah, Doctor Astha, can you unmute yourself? You can try once. Yeah, Dr. Astha will try.
Okay, Asta, just to see what you are seeing and can you describe what you are seeing?
So the EEG is not completely visible.
No, I am not talking about EEG.
Video, sir?
Sir, video also not visible.
Not visible, huh?
No,
Yes,
sir.
sir. Only it is blank.
Okay.
Only EEG is visible, but video is not visible.
Video is not visible. Are you able to see now video?
No, sir, no.
No, sir.
Just to see the I'm having difficulty to play the video. Like in this one, at least, if you see the EEG.
Yeah, later describe one.
Yeah. Asta, you are seeing EEG here, na?
Yes, sir.
So you are finding some abnormality.
Yes, sir.
Sir, can you describe the video once? Then she can describe.
Video is a 4-year-old child. Okay. When he is sitting during the EEG, he had a small amplitude jerks of both the shoulders.
Okay, sir.
So this is the EEG of the child, and I am reducing the amplitude. Now you can see. This is a bipolar montage. And changing to average. Okay, you are seeing something now?
Yes, sir.
What you are seeing?
Sir, here in the, sir, this is a long average differential montage with sensitivity at 500 microvolt per centimeter, high cut filter at 40 hertz and low cut filter at 1.6 hertz. Here the background is normal, and there are 3 to 4 hertz eigenwave discharges seen in the 5th second of this epoch, and they are generalized.
So at least one clue what we got from yeah, tell me.
Yes, sir.
Yeah, one clue what we got is we have almost, you are seeing the spike and wave discharges. In a second, almost you have a 3.
Yes.
So we know that we are dealing with some kind of the generalized epilepsy. Okay.
Yes.
So is a 4-year-old child, came with the bilateral shoulder jerks and this kind of EEG. So it is like a myoclonic absence seizure.
Yes.
So okay, I will show the one more EEG. Asta, are you able to see EEG?
No, sir, not yet.
Are you able to see now? Asta?
Yes, sir. Now it's a small. Yes, sir.
Are you able to see?
Yes, sir.
Yeah. What you are seeing now, video you are not able to see, no?
No, sir.
Yeah. So you are seeing something. Now, what is the change you want me to do in a montage?
So sensitivity I want decrease.
Okay. Okay.
So a little bit more to 150.
Little bit more reduce, huh?
Yes, sir. Now.
Okay. Any other change you want?
Sir,
Okay.
here we can see. So again, there's a generalized discharges, spike and wave, spike and wave discharges being seen. And as it's lasting for 10 seconds, so we can consider it to be an electrographic seizure.
Yeah. So this is also, I am not able to show the video, but this is like a typical absence seizure where
Yes.
you can see I can just increase the sensitivity a little bit. You can see you can see spike and wave like discharges. Your spike and slow wave is like a dome. Okay. So you can see the duration is less than 10 seconds. And if you see the one more event also, it looks the same. If you see, it is almost 10 to 12 seconds.
Yes.
And it is in the OPD record. So you can see how many you can record in an hour. So it is a 10 seconds. And it was lasting little more. It is a 15 seconds. Okay. I'll show you the one more EEG. Asta, are you able to see EEG?
Not yet, sir.
Now?
No, sir. Sir, share screen with that. You have to again share the screen with this. By clicking on this again, share screen.
Are you able to see?
Yeah, now it is.
Yes, sir.
Asta, are you able to see?
Yes, sir. Now it's visible.
Okay. Can you see? Can you describe what you are seeing in this one? How it is different from the previous one? So I'm reducing the sensitivity. I'm changing the montage to average.
Yes, sir.
Sorry, sir. Okay. So you saw now first EEG you saw only just 1 second. Okay.
Yes.
Second
Yes.
one almost you saw the 10 to 15 seconds. This one. You see how much you are seeing this one?
Sir, it is lasting throughout the epoch,
Yeah.
more than 10 seconds, and the frequency also is slightly higher. It is 4 hertz, reaching up to 4 hertz, sir.
Okay.
3 to 4 hertz of frequency, generalized spike in wave discharges, and they are seen throughout the epoch for more than 10 seconds.
Okay, you see, like, so this is 10 seconds, na?
Yes, sir.
This is 10 seconds.
Yes, sir. It's 10 seconds.
11, 12, 13, 14, 15, 16, 17, 18, 19. So it is almost 20 seconds. Huh?
Yes, sir.
So I'm showing the one more same. So 10, 11, 12, 13, 14, 15, 16, 17, 18. So what do you think this one? Same, like you know that you are having a absence like episode only, na?
Yes, sir.
But always if you see the duration is much more longer.
Yes, sir.
The age is the 17 years old.
Yes, sir.
So what do you think this one?
So possibility of juvenile absence epilepsy is there because of the frequency is high.
You are seeing the one is juvenile and
juvenile myoclonic absences also.
hello.
Yes, sir.
So one is a juvenile absence, but we don't have any other thing what you can think of. Na? When you see a 17 years old having a long absences, very frequent absences, it is likely to be a juvenile absence one.
Yes, sir.
Right. So if you see a juvenile absence epilepsy, the peak age at onset is 19 to 13 years, but it can range from the 5 to 20 years. Frequent and the severe typical absences are the characteristic and the defining feature. 1 to 10 per day, but this may much higher for some people. Nearly all patients also develop the GTCS, and the fifth of them also suffer from the mild myoclonic jerks. Normally, these juvenile absence epilepsy, their myoclonic jerks, normally you see in individuals, myoclonic jerks in IGEs are predominantly during the early morning hours. Whereas in a juvenile absence epilepsy, you see the myoclonic jerks at the end of the day when you are getting more fatigue. And myoclonic jerks in the juvenile absence epilepsy are more common around the eyes. And the hallmark of the absence is same abrupt, brief, and the severe impairment of the consciousness with the total or the partial unresponsiveness. Automatisms are frequent, usually occur 6 to 10 seconds after the onset of the EEG discharge. But very mild, simple automatisms. And mild myoclonic elements of the eyelids are common. Duration varies from the 4 to 13 seconds, and it is usually long. On average, it is 16 seconds. GTCS occur in 80% of the patients, mainly after awakening, although nocturnal and the diurnal GTCS may also be experienced. Absence status epilepticus occur in 20%. Mental and the psychological arousal is the main precipitating factor for the typical absences. Conversely, sleep deprivation, fatigue, alcohol, excitement, lights alone are usually in combination are the main precipitating factors for the GTCS. And autopsy and MRI studies found microdysgenesis and other cerebral microstructural changes in patients with JAE. So normally, the most of the time, what the problem we encounter is because we keep the patients on some drugs, EEG changes will happen with them. So you see the both focal discharges and generalized discharges, and it is the history actually which gives a clue, and the age and the type of discharges which gives the clue that we are dealing with the JAE, because it is commonly mistaken for the complex partial seizures of the temporal onset.
Sir, that can you close this EEG and start your other whatever you are speaking, that PPT. Can you share that one?
Okay, one second. Here we can see. Stop.
Okay, sir, go ahead. It is given.
Yeah. Okay. So we saw a 3 share, na? Like, are you able to see na, Shailesh?
Yes, sir, yes.
Shailesh?
Yes, yes, yes.
Yeah. So prognosis in a juvenile absence epilepsy is a lifelong disorder, although seizures can be controlled in 70 to 80% of the patients. Absences tends to become less severe with age. Because of the frequent combination of the absences and the GTCS, the drug of choice is valproate, which controls all seizure types in 70 to 80% of the JAE patients. Lamotrigine and the levetiracetam are other options. Treatment may be lifelong because attempts to withdraw medication nearly invariably leads to relapses. And other one is next we are going to juvenile myoclonic epilepsy. All of us were very familiar and the very common disease. And the JME is characterized by the myoclonic jerks on awakening, GTCS in nearly all patients, typical absences in more than a third. Absences are not very typical in juvenile JME, juvenile myoclonic epilepsy. These myoclonic jerks are shock-like, irregular, and the arrhythmic clonic movements of the proximal and the distal muscles, mainly of the upper extremities. 1/3 of the patients have typical absences with subtle impairment of the consciousness. Myoclonic status epilepticus starts on awakening, precipitated by sleep deprivation or missing medications. Usually conscious remains preserved. Seizure precipitants in JME are sleep deprivation, very common, fatigue, mental stress and emotions, and drug default. And around 50 to 60% of the families of the probands with JME report seizures in first or second degree relatives. Proposed models of inheritance: polygenic with lower manifestation threshold for females, autosomal dominant with variable penetrance, a 2-locus model with a dominant gene on chromosome 6p and as yet unknown recessive gene. Different genes have been identified linked to the JME. And EEG shows the 3 to 6 Hz generalized spike and wave discharges with inter-discharge fragmentation and unstable intra-discharge frequency. Means intra-discharge fragmentation means you can see sometimes the focal discharges, and unstable intra-discharge frequency means sometimes you may not see the 3 to 6 Hz, either less or more. 1/3 of the patients shows the photoparoxysmal response. 1/3 may also have a focal EEG abnormalities. So avoid triggers. Valproate is the drug of choice, but like in female gender, we will use the levetiracetam. And the clonazepam in small doses is effective for the myoclonic jerks. Contraindicated drugs are vigabatrin, tiagabine. Anyway, we will not use pregabalin, gabapentin. So avoid the phenytoin, oxcarbazepine, and the carbamazepine. Epilepsy with GTCS only, prevalence unknown. If the strict criteria apply, this may very small. Age at onset is from 6 years to 47 years. 80% have their first GTCS in the second decade of their lives. Males are affected more than females. Neurological and mental status are normal. All patients suffer from the GTCS. GTCS occurs on awakening, during awake, during sleep, or randomly. They are genetically determined. And the seizure provoking factor, same for everything: sleep deprivation, fatigue, or excess alcohol consumption. And interictal EEG, usually normal background with generalized discharges of the spike or multiple spike waves in half of the patients with GTCS only. 70% of those with additional mild absences are myoclonic jerks. 13% shows the EEG photosensitivity. And the ictal EEG prognosis is a high incidence of the relapse and withdrawal of the treatment. The interval between seizures becomes shorter with time. GTCS may become random, either as a result of evolution of the disease or drug-induced modifications. And here also valproate, lamotrigine, levetiracetam, phenobarbital, and topiramate, carbamazepine, phenytoin, oxcarbazepine can be considered. But in some people, we don't know. We always say that in a generalized epilepsies, avoid sodium channel blocker. But in some, like maybe in this one where GTCS on awakening, some people respond very well to carbamazepine or the phenytoin. So these are the in a children benign familial neonatal convulsions. Only 50 patients have been described, so it is very rare. It is a potassium channelopathy, KCNQ2 receptor, and they are very sensitive to the phenytoin. And children normally present with the clonic movements. Prognosis is good, and even benign myoclonic epilepsy in infancy is also, it is the earliest form of the IgE. Almost 1 to 2% of the epilepsies that starts before the age of 3 years. Age of onset 6 months to 3 years, but earlier or later can possible. Male predominant. Myoclonic jerks, either single or cluster. Consciousness is intact, but mild clouding may occur during the cluster of the jerks. No other types of seizures other than the simple febrile seizures in 10%. Seizure precipitating factor, same photosensitivity, unexpected acoustic or tactile stimuli, usually during awakening or during the first hours of the sleep. EEG shows the generalized polyspike and wave discharges. Valproate is the drug of choice. So like previously, these syndromes are not recognized in ILAE. These are like a idiopathic generalized epilepsy with absences of the early childhood. If you see the typical absences in the early part of the childhood, around 2 years or 3 years, and they will not respond to the drugs, and their prognosis is not good. And in these people, look for the GLUT1 receptor GLUT1 deficiency. And other one is a perioral myoclonia with absences. It is also same as the typical absences, but they have a myoclonic jerks around the mouth, and EEG shows the similar 3 to 6 head spike and wave discharges. They also have a other GTCS and other ones, but most common ones are the absences. They are little resistant to the treatment. And other one is eyelid myoclonia with absences. It is typically associated with the rhythmic fast jerking of the eyelids, often with upward deviation of the eyeballs and retropulsion of the head. Especially they have a very high photosensitivity, and it is like a sunflower. Like if you are turning the light in a, like if the child has a G1s, and if you are turning the light around the 360 degrees, for example, the child head also rotates along the head. That is the kind of photosensitivity they have. and they have a absences, GTCS and myoclonic jerks. Valproate is the drug of choice. And this is also very rare idiopathic generalized epilepsy with the phantom spikes, phantom absences. It is a simple absence-like episodes. They are mild, inconspicuous to the patient and observer. They have a this syndrome also includes the usually late onset IgE, late onset GTCS. So especially if somebody has a GTCS in the late onset and they have a very transient, typical, simple, partial, simple absences. And here also same thing. Okay, I thought I will show the EEGs and I think, but it is looking difficult to show. Okay. Like what we learned today was a idiopathic generalized epilepsies are the electroclinical syndromes, and initially they are labeled as a idiopathic generalized, but the later terminology is a genetic generalized epilepsy, and they start from the childhood, and initially all the IgEs have a common association of the absences, myoclonic jerks and the GTCS. What dominates in that is depends upon the characterization. For example, if you have a myoclonic jerks being the very dominant, it is a JME. If the absences are the dominant, it is a JAE. And if the perioral myoclonia is dominant, it is a perioral myoclonia with absences. If your drop attacks are dominant, it is a myoclonic astatic epilepsy. So based on the association of the, if your eyelid myoclonus is dominant, it is a G1s. So what is common is the dominant symptoms are common, and one may be a more, if the GTCS is common, it is a GTCS on awakening. And all the syndromes will show the same thing, generalized spike and wave discharges. And the frequency varies from the 3 to 6. The drugs can modify the EEG features, and sometimes you can see a focal, but we have to, based on the other features and the history, you can decide what syndrome it belongs to. Okay, Shailesh?
Yes.
Hello?
Sir.
Yeah.
Yes, sir. Yes, sir.
Shall we close? Yeah, anything?
If you want to continue for another half an hour, we can continue, sir.
But I'm not able to show the EEGs. I prepared, but somehow videos are not playing and something. I thought I want to make.
If you want to share in the group, then somebody can project.
How to memory? There is a lot of memory, na EEG ones.
Yeah. Is it possible to share in the EEG? This.